Thank you for the invitation. Now, since we saw that bronchoscopic lung volume reduction is an eclectic procedure, I will show you how to democratize this for inflammatory lung disorders and keep it on a wider spectrum. Okay, so we'll talk about first for asthma, which is probably a paradigm to investigate, and then we will switch to chronic bronchitis, which is at the moment in evolution. So we know that asthma is a very serious disorder because it affects a lot of people around the world. It causes also deaths. It is the most common chronic disease in children, and there are some problems, especially in poorer countries where diagnosis and therapy is a burden and it's really challenging. It is not cured, but it can be treated promptly. The prevalence is increasing. Here you can see data from the United States. We are not sure if the prevalence is increasing or we are getting better at recognizing asthma and treating it promptly. So you see that we expect these rates to go even higher. For severe asthma especially, this is a clinical challenge because at the moment there is a lot of research of how we treat these severe asthma patients, and we have to separate between certain conditions. We have the high intensity treatment, so we have people who have asthma, but with really a lot of medication we can keep them happy and live a normal life. We have difficult to treat asthma, where despite high intensity treatment, we have poor symptom control, and usually these are people who have to be revisited and treat and think about how they treat themselves, how they take their inhalers. So in this group, re-evaluation of the treatment is necessary. And then we have this pure 3.74% of really severe and difficult to treat asthma, where we have trained the patients, they know how to use the inhalers, they use high intensity treatment, a lot of bronchodilators and inhaled corticosteroids, but despite this, they are not well. So there is an unmet need in severe asthma, and this is because we usually have a lot of remodeling of the airways in severe asthma. You see here on the left side we have a normal airway, and on the left side, and on the right side we have an airway of a patient with severe asthma. And what is very profound is that the lumen is much narrower. So we have increased airway wall thickness, we have a lot of mucus obstructing the airway. So this is the exact problem in pathological samples. You see, the lumen is really decreased. So there are some methods which were developed some years ago to how to alleviate this problem. This is the bronchial thermoplasty, and as you can see, it depends on really simple tools. It just needs a catheter, which is a radiofrequency catheter, ablation catheter, and a small generator. And we used to treat patients with severe asthma who remain symptomatic despite this maximum inhalatory treatment, and our aim was to reduce the smooth muscle cells in their airways. So we were using the radiofrequency ablation in order to destroy these muscles and make the airway wall more loose. So there is a very specific way to do this. There are 3 sessions at 2 to 3 week intervals. First, 2 are for the lower lobes, then we have a third for both upper lobes, and we do not treat the middle lobe because it tended to shrink and create bronchiectasis. We were not sure about how this method works, how it acts on the smooth muscle cells. There are some theories, but in fact it works. In pathology samples, we see that if we do bronchial thermoplasty, we can decrease the muscle cells in the bronchial wall. Sorry about this. So I will start a little bit later. This is the actual method. You can see we go with the bronchoscopy up to the distal airways, and then we deploy this catheter. It's an actual simple method. It's rather boring for the bronchoscopist to do it. So the catheter opens, comes into contact with the wall, and then we start with a burst, which are regulated by the generator. And then we close the catheter, and then we go to the adjustant part and we do it again. And that's how we treat first the lower lobes in 2 separate sessions, the upper lobes in 1 session, and we leave the middle lobe. And there are a lot of studies about bronchial thermoplasty. The last one that I have put in circle is the AIR2, which was the most complete study because it was a randomized trial and a sham control trial. So people were actually having the bronchial thermoplasty or having a bronchoscopy without having the thermoplasty. So it was the placebo effect, as explained previously, could be alleviated and we could have the real data. Unfortunately, this is it was a big study, 288 adult subjects, and they had these procedures. They were randomized, and it was very precise because they used the asthma diaries and they used them electronically. So every patient got an electronic diary and marking his symptoms. And these are the results. Unfortunately, you can see in the just on the right column that there was no statistical significance among the groups. There were differences, so patients were getting better, but unfortunately this did not succeed statistical significance. So there were a lot of questions about this trial and the future of this method. Was it a positive trial? No. The secondary endpoints were met, quality of life, dyspnea scores, whatever. No. So we had the reductions of asthma exacerbations and emergency room visits and hospitalization. We had, but again, not at a statistically significant level. And these were secondary endpoints. They were not part of the primary endpoint. So it was actually a negative study that showed some very positive things. So maybe we are at a position where we are not exactly sure which people to treat and which people can benefit. As with bronchoscopic lung volume reduction, we were not sure before having a complete fissure was important. Maybe we are in such a situation at the moment. And also, some patients had pneumonitis. This is not very common in the study, but there were cases where there was some thermal damage, and you can see here some images from a pneumonitis. And also, to have even a more interesting talk, we are at the level of, we are at the era of biologics. So at the same time where bronchial thermoplasty evolved, at the same time we had monoclonal antibodies coming into severe asthma. And this completely changed the picture of severe asthma, because indeed with monoclonal antibodies and the newer treatments, we had very significant responses in quality of life, in asthma scores, in everything. So for a moment, bronchial thermoplasty seems to have lost its place. So indeed, in Europe and in the States, there are not many procedures done. But still, there is a recommendation from BTS, as you can see here. It is a possible treatment option for centers that can offer it. And also, we have to search of a phenotype. In the era of biologics and where people are treated for Th2 asthma, maybe bronchial thermoplasty can be very successful for non-Th2 patients. And we had some sub-analysis in the previous randomized trial that was showing this. So it could be an option for non-Th2 patients that are not able, they are not responding to biologics. So we could use bronchial thermoplasty in this aspect, but this still needs to be studied. So following this paradigm of asthma, all this methodology of treating the airways was shifted to COPD and chronic bronchitis in particular. So we had this method, which is the bronchial thermoplasty, but it's called rheoplasty now, for the treatment of chronic bronchitis. And it specifically aims for a very nice phenotype of the person who has a high CAT score, so he has a lot of sputum, a lot of dyspnea, a lot of symptoms from his bronchi, and less to emphysema. So we have a treatment now that is aiming a lot of patients. And you see here, this is a first study, which is quite recent and very well made, with 30 patients who had a moderate to severe COPD. And they were treated with these short bursts of through this electrical catheter. And it's almost the same setting. So we do it with bronchoscopy, flexible bronchoscopy. Most procedure in this study, a general anesthesia was used because the patient had to be completely still to do it. And we started from the subsegmental level, working our ways up. 2 different sessions for the right lung and for the left lung with 1 month interval, because there is a risk of exacerbation in this patient. So we cannot treat both lungs at the same time. And you can see here, very, very similar technique. Go with the bronchoscopy down to the segmental level as low as we can. And we treat, you see the catheter is very similar to the bronchial thermoplastic catheter. Again, we expand and we treat with electrical energy. And now what happens is different. We do not aim for the muscle cells here. We aim for the complete mucosa. So we aim for a remodeling of the mucosa, and we need to kill the goblet gland cells that produce the mucus. So we transmit the energy up to the basement membrane, and then the mucosa is completely sloughed, and then from the extracellular matrix, the regeneration process of the bronchial mucosa starts. And when the regeneration process is completed, then we have a new airway. So no goblet cells, no production of mucus, and of course also the muscle cells are affected. So it is proven that it's an efficient treatment. And you see here a picture prior to treatment with a lot of mucus, and afterwards 1 month where the goblet cells have gone and we don't have mucus anymore. And you see the histology picture as well, where there is a complete regeneration. You see that in the lower picture it's much less dense, so the goblet cells have almost completely disappeared. So we are talking about the regeneration of the mucosa. So this is very promising in 30 patients. And from this study, it was shown that we had improvements, reduction in the pathology statistics, but also improvements, clinical improvements in the CAT score, in the quality of life scores. There was a significant change in the people's lives. This is what is presented by the company at the moment. This is the latest. It was presented in ATS. This is the American study, so they had also 21 patients. You see small numbers still, because the company is still assessing safety for this procedure. And this procedure seems quite safe. You can see here that they had 4 serious adverse events, which were COPD exacerbations, understandable because we are treating the airway, so exacerbations can happen. They had 1 pulmonary embolism, and they had 1 patient with a lot of dyspnea. But there was a 31% reduction in moderate or severe COPD exacerbations, which is important for this group of patients. So this method is promising. There is a clinical trial going on. You can find in the clinical trial list or from the site from the company, you can find more information. And it is important to focus on this technique and have it in mind, because I think it is something that will work in the next years. As soon as this randomized trial is completed, they will have also the FDA approval. This is CE-marked method. So if you want to take this machine to your bronchoscopy suite, you're able. But this is not quite right, because the randomized studies are not completed. So we are not sure. We have a first signal that this is very significant and statistically important for the patient, but we do not have big studies. The best thing is to do is wait for this randomized trial to be published, and then maybe we can start and acting on this method. Also, it has to be stressed that these methods are not cheap. The catheters and the evolution of all this process costs a lot of money. So it will not be cheap, and it will not be reimbursed by the insurance by the system in general anytime soon. So moving to a second method, the targeted the lung denervation. This is the simple electrode. It acts on the parasympathetic pulmonary nerve input to the lung, and it aims to reduce clinical consequences of cholinergic hyperactivity. So it seems that it works a little bit like our tiotropium, okay? but it seems to have a lasting effect. It is a procedure that needs a lot of care because acting on the parasympathetic system can mean that you can cause gastrointestinal problems to the patient. If you treat the esophagus and the esophagus is not working properly, so you can have some serious problems with the motility of the esophagus. Nevertheless, for experienced people that do it, and you can see here, this is a presentation from some years ago from the ERS where they did a live case. This is Felix Hirth doing the procedure. It seems that it's quite safe. So you can see here the chart with the actual adverse events. There are some problems on the mucosa. So if you do a denervation on the mucosa, you can have some perforations, you can have some ulcerations, not serious and not very common. And also some people had difficulty to swallow. So usually this was transient. If the procedure is correct, you do not have permanent results. And you can see here a little bit also a slide of the targeted lung denervation. So this has a more intricate procedure. So you have to treat with this electrode, which is inside a balloon that is filled with water because it creates a lot of heat. So the heat has to dissipate. So we treat the points where the parasympathetic nerves are. And because they're on both sides, so we had to deflate and go round and do the other side as well. So it's a little bit more intricate as regards. And of course, we avoid all segments that are adjacent on the left side with the esophagus. So it's something that has to be developed. It's not as simple as the previous techniques, but the authors and the people who are developing are very adamant that this will have a future because you see, excuse me, first you see here some ulcerations. There are some ulcerations and some granulomas formed. This is not very common. You can see in the right pictures that we have this kind of complications, but usually they are not severe. And the results are not very fantastic yet. So these are 3-year results, and it has been shown that these patients who have a really severe picture of exacerbations are kept stable. It's not like they're improving a lot, but they do not have a lot of exacerbation, they do not have a lot of dyspnea, they are keeping stable. And you can see the exacerbation rate, you can see the quality of life, you can see the CAT score, that is kept stable. Stability sometimes can be quite an important issue in these patients as well. So this needs to be studied. That is why there is an Airflow 3 study. The previous slide was from Airflow 1, the 3-year results. So now there is an Airflow 3 study, which will end by April 2027, and then we will have more data on this, and we will see if this will continue in the future. If stability is an issue, we can offer it to our patient. If this study shows even more good results, maybe it will work even further. The last method I would like to show is this metered cryospray. So we use this catheter to eject cryospray made of nitrous oxide directly to the airway. So, and we aim to create a cryo damage on the mucosa, slough the mucosa up to the basement level, and then let again the extracellular matrix create a new mucosa which is much more healthier than the previous one. So again, we aim for mucus hypersecretions and damaged cilia. We spray this nitrous oxide, we destroy the mucosa, and then through the extracellular matrix, we have a new mucosa which is much healthier, as you can see also in the pathology samples on the right side. So of course there is also treatment. We will first treat the right lower lobe to the main stem, then afterwards, after 2 months, we treat the left lower lobe, and then we go to the upper lobes. So similar techniques, similar way of splitting the procedures for the patients. And the results were quite good as regards quality of life and CAT score. You can see an actual endoscopic image of this technique. And I don't have any personal experience. I have seen the other techniques. With this one, there are not a lot of data around. There are some recent publications, and for sure there is a new recruiting study at the moment which takes place in the States, and it will have 210 participants randomized with sham control. So we will have more data on this. And so we probably will have 3 new modalities to use in chronic bronchitis, which is quite a common phenotype. So probably we will have some news in the next year. So you can see a scheme that summarizes everything. We can have vagal nerve ablation. We aim with a cryospray from the mucus glands, and we do our rheoplasty as well for sloughing the mucosa. And with that, I will thank you for your attention, and I'm open to questions.
Obstructive lung disease is an indication for bronchoscopy, isn't it?
Absolutely. Absolutely.
Okay.
Of course, this will be quite expensive, and this must be very carefully advocated with these randomized studies in order for the systems to support in Europe and in the United States.
Thank you for this presentation. It was excellent, very interesting. I just have two questions. First, for the nervation. How can we choose the exact spot where the nerves are?
We don't. We do it sequentially in all cases. Okay. The targeted lung denervation needs a little bit of training. So the important thing is to do right and left side in each bronchus. So it takes time. All these procedures take a lot of time, more than 1 hour to treat. Okay. It's not very intricate as a methodology. The only thing for targeted lung denervation is on the left side. They have very specific points which are to avoid the esophagus. And I can show you the procedure that was done in the ERS live from Felix Herth was done under fluoroscopy to know exactly where the catheter is placed. So this is more intricate, but as regards the rheoplasty, it's a very simple procedure and it resembles bronchial
this is the
thermoplasty.
second question about rheoplasty. What about the patients who have chronic bronchitis? They're very symptomatic, but they're not COPD patients. They're not like obstructive patients, but they have chronic bronchitis.
The studies recruited patients that had moderate or severe obstruction mostly.
We don't know if we can do it.
It depends on the symptomatology. CAT scores are important, so they had patients that had a high score on sputum and the CAT score, but they did not recruit patients that are, let's say, in a more mild phase. But from our experience, the pharmacology of chronic bronchitis is quite difficult. I don't know your experience, for example, with roflumilast, which was considered a very promising drug for chronic bronchitis, and more than half of the patients cannot tolerate it because of side effects.
This is why I'm asking, because pharmacology is also problematic, so we don't have
absolutely
a lot of things to do with this.
But imagine, when we have chronic bronchitis patients, we use tiotropium to dry their secretions, right? We can have a more permanent thing to dry their secretions, but as we discussed with Professor Statakos, it remains to be seen if this is a very expensive tiotropium. Okay, so we have to see actually the data. But from my experience, I have an unmet need in patients with chronic bronchitis, COPD, that have a lot of exacerbations, a lot of sputum. It is not a hyperinflation that it's their main problem, but we cannot simply not give them the quality of life that they deserve. So it's an unmet need.
I think the overall message is, yes, we can treat some of the problematic patients with obstructive lung disease, either emphysema, bronchitis, or asthma, but it's not for all of them. We have to be very, very selective and very detailed in our selection. For example, for BT, it looks the most problematic question is which patient. Of course, not the patient who can take biological.
Yes,
that's clear. Non-H2, non-inflammatory, the post-inflammatory phenotype of asthma looks like it is the most probable candidate. Also for emphysema, I showed a lot of selection, but also for chronic bronchitis.
I can give you an example. I had a patient, very young patient, 35-year-old, an atopic, allergic, severe asthma patient who did not respond to omalizumab at the point where we, just before mepolizumab came to the market. And we were actually considering of sending him for bronchial thermoplasty because we didn't have the exact machine at the time to send him to Heidelberg and do it. And he said, I told him that he could get an exacerbation, had 2 young children. He was considering it a lot. Like his quality of life was very poor, and he was considering, but he was afraid. And I told him, you know, we can look for it, we can try it, because this is not life. This is terrible. Corticosteroids, corticosteroid-dependent exacerbations every month. He started with mepolizumab. As soon as it came into the market, his life was transformed. He's now a healthy individual. He takes his bronchodilators, he's steroid-free, and he's another. So immediately with one injection, everything went away. On the other hand, we have an older lady who is corticosteroid-dependent, non-Th2, that she's having every month an exacerbation, despite the corticosteroids. This could be a good candidate for bronchial thermoplasty. And this could be advocated, but we don't have simply the direct face-to-face studies that say, okay, we have to see bronchial thermoplasty versus biologics and see the non-Th2 response. And I'm afraid for bronchial thermoplasty, because there are a lot of studies for non-Th2 at the moment with new molecules, that the new molecules, because the industry is pharma-driven, okay, medication, I think we will not have any data on this because we will have no Th2 drugs now, and the bronchial thermoplasty will fall. But I gave you this paradigm because we used all this data for chronic bronchitis, because in chronic bronchitis we will not have these biologics. So it's a very good field for IP.
I think what was clear through this presentation this morning is that interventional pulmonology is not just techniques to master. It's a lot of science behind and a lot of pulmonology behind. So being interventional means that you have one more arm, one more possibility to treat your patients. It's not like you forget to be pulmonologist. We're pulmonologists, but we have also a spectrum of possibilities that standard pulmonology does not support. So we can support our patients with more alternatives. And if there, yes, please, Kostas.
Thank you very much. This is a question that may apply to both of you, both previous talks. Some patients with COPD has also tracheal bronchomalacia, excessive dynamic airway collapse. And this is maybe a big factor in their symptoms and debilitation. How do you assess and treat them? With stents or other options?
That's another talk. But
of course, these patients are not included in these categories. And they're different. Tracheal bronchomalacia is different from excessive dynamic airway collapse. They're very difficult problems to treat. A short, a brief answer would be that for malasic patients, very rarely we can benefit from stents. So stents, which has been tested many times for malasic patients, rarely works well because the choke point migrates distally. So you put a stent in the airway that you see that is collapsing, and then the collapse migrates in the periphery. So you gain not many things. We often use non-invasive mechanical ventilation, CPAP or BiPAP for these patients. And sometimes we can also think of some operation to treat malasic airways. So it's a difficult chapter. As for the excessive dynamic airway collapse, which means that the cartilages are intact and there's only excessive movement of the membranous part of the trachea or of the main bronchi, usually this is due to inflammation in the bronchi. So we treat first inflammation, either it is infection or other type of inflammation. We also may try some non-invasive ventilation, but there are also some strategies with bronchoscopy to produce ulceration of the membranous part to make it shrink. So we laser or we cauterize in a very structured fashion the membranous part, and we can shrink it because of the thermal destruction, so it gets less elastic and it moves less. There's also some surgical strategies with plication of the membranous part. They suture the membranous part so they impede it from moving too much. So it's another chapter. We'll look into two talks, one on the Malesic patients and one on the excessive dynamic airway collapse. Yes, please.